It's a phenomenal achievement by the Tamil Nadu Ophthalmic Association. Thanks to our dynamic president and secretary, Dr. Thangavelu and Dr. Madhavan, for this wonderful effort. And I kindly request Dr. Thangavelu, president of the Tamil Nadu Ophthalmic Association, to address the gathering and say a few words.
Morning, everyone. Welcome to the TNOA session on court martial. Happy to see you all once again in good health. I must thank, first of all, Dr. Mohan Rajan, Ravi Shankar, for this tremendous effort they're taking every month. It is not just 1 month and leaving it away. Organizing a webinar, calling everybody. I know the pressure. I know they've done a good job. We must all give them a big hand for what work they've been doing. And I think they will be doing it till the next conference also. So give them a big hand. If what we speak today is recorded and can be replayed anytime, you must all remember Thomas Edison. He uttered, "Mary had a little lamp," to the mouthpiece. This was captured and heard. This happened today, November 29th, in the year 1877. Thanks to the sound innovation, let us make it melodious. Way back in 1980s, I remember the days, retrobulbar block, knife section, intracapsular cataract extraction, and many steps were never in our control. Vitreous prolapse, its management, magnified images of the spectacle correction, and much more. All this is history. We have come a long way. Better understanding, skilled trainings, techniques, and technologies have changed the way we approach not only cataract, but ophthalmology as a whole. We could have done better even in those days if we had access to technologies to record, document, and present. Much more than that, expert juries, judges, and court martials like this to put us on the right track. Thanks to such novel events for helping us to learn and compete for perfection. Presenters have come here as their juries to showcase their evidence as how to manage the tricky or unusual situations or normal situations with unusual turn of events and prove that they are not guilty. Experts, experienced, are here juries as judges and moderators to listen to attorneys' views and pass on a verdict, not only acquit or convict, but also to tell us what best would have been done at that circumstance. Humans always quest for perfection. This is achieved by willingness to learn, change, perseverance, and experience. This will not come overnight. Never forget, we have all gained experience from bad judgments. Wish that all of us remain genuine judges. Wish that all of us remain genuine judges of our imperfections. Never an expert advocate for our misfortunes. Learn to never utter an adverse comment to gain advantage from another's management. We never know the background, circumstance that followed, and thereafter, the whole story. It is only a perception. Go by practical wisdom, good sense, and moral reasoning, remembering that we are being judged. As Siddhartha Gautam Buddha put it very simply, it is easy to see the faults of others, but difficult to see one's own fault. On this auspicious Kartike Deepam, let's observe the facts, figures, and faults and learn the verdicts of our honorable judges, juries, to enlighten the vision and minds of our millions. Thanks once again to the organizers for giving me this opportunity. And thanks the managing committee members also for giving me this opportunity. Thank the sponsors, especially Numeritech, for every webinar. He's been with us. He's doing a very good job. Thank you once again. Back to Dr. Mohan.
Thank you, President, for the inspiring address, as always, because you always lead by example, and you have different quotes, and that will always motivate us to do better and better. I think it's a teamwork. It's not only me and Ravi Shankar, it's the entire teamwork of the managing committee and the TNOA, which has made the huge difference as far as the webinars in this pandemic era is concerned. Over to the secretary, dynamic secretary, Dr. Madhavan, to say a few words.
Thank you, respected President, sir, office bearers, and panelists of this exotic TNOA court-martial webinar. And of course, the members of TNOA and all the ophthalmic fraternity all over. A very pleasant good morning to you all. At the onset, my sincere thanks to Dr. Mohan Rajan and Dr. Ravi Shankar, for their continued efforts for the monthly webinars during these testing times. Since our last webinar, I'd like to highlight some of the events that have taken place. Dr. Mohan Raj, our very senior TNOA member, was honored with the Best Doctor Award by our IMA state during the Doctors' Day celebration last week at Chennai. Myself, Dr. Nirmal, Dr. Raj Shekhar, and Dr. Nehru were there to greet him on that occasion. And our president, Dr. Thangavelu Sir, has been awarded the prestigious Dr. C.B. Bhaskaran Award and Oration by IMA, and he'll be delivering that oration next Sunday on 6th December virtually. Please do keep that time date free and to hear our speaker, Dr. Thangavelu Sir, speak on that occasion. Congratulations, sir. To keep our association activities updated in administrative sphere also, we are in the process of conducting a special general body meeting on 27th December virtually. We'll keep you updated in the future. In a far-reaching notification by the Central Council of Indian Medicine, which has notified that the PG courses in general surgery, ophthalmology, ENT, dentistry, all in Ayurvedic education also. All these procedures fall under the ambit, the authority, and the jurisdiction of modern medicine. This encroachment is a blatant mixopathy. Patients have the right to choose the system of medicine, and it is taken away, which is detrimental to general public. Each system of medicine should excel in their own domain and help the patients. With this in mind, the state IMA and the national IMA are preparing for a long-drawn struggle for existence and for our own identity. We too will join hands with IMA to resist this ill-advised adventurism. We shall keep updated as the situation progresses. Thank you once again, and looking forward to this wonderful, exotic webinar. Thank you.
Thank you, Dr. Madhavan, for guiding us always. Your advice, the right time, I think it's a great thing for all of us, and we are really blessed you as a TNOA members to have you as a secretary of the TNOA. And
Thank you, sir. Thank you.
This webinar is a Tamil Nadu Ophthalmic Association Court Martial, and it's going to be slightly modified. It's a modified version of the original court martial, which was introduced by Congress. So it's not going to be the usual public prosecutor and all that, because it's all available. Kindly mute, please. And it's going to be a little modified. Dr. Ravi Shankar will probably talk about it. But I would like to introduce the jury members and also the Supreme Judge. The Supreme Judge is none other than Dr. Siddharthan. As you all know, Dr. Siddharthan is the past president of the TNOA. He is the director of the TMS Eye Hospital. He is one of the dynamic cataract as well as vitreoretinal surgeon, and he is the leader as far as the TNOA is concerned. He is a visionary par excellence, and we are very, very happy and glad to have him, honored to have him as a Supreme Judge who will take the final decision as far as the speakers are concerned. Then we have an expert jury, expert panel, actually a galaxy of panelists, and starting from Dr. Sukumar, past president of the TNOA, and he's got his own establishment in Erode. He's a very, very busy practitioner, veteran. He's an active role in the IMA as well, and he has got a good knowledge of the medico-legal aspects as also. And of course, we have Dr. Ramakrishnan, the vice president of the TNOA, and director of the Aravind Eye Hospital, Tirunelveli. As you all know, he is a glaucomatologist par excellence. Everybody knows him, and he doesn't require any introduction. He'll be a great addition to the panel as well. And of course, Dr. Nirmal Frederick, and who runs the Nirmal Eye Hospital. former editor of the IJO. He has taken IJO to a different level. Last week, we saw a fantastic webinar by Nirmal and Sharmila and the current editor on the research methodology, which was very, very useful. One of the most informative webinars I have ever seen. Hats off to you, Nirmal, for that. And it's be a pleasure to have you. Nirmal has also got an active role in IMA as well. And of course, Dr. Chitra Ramurthy doesn't require any introduction. The most dynamic lady on this planet, I would say. She's the chairman of the ARC. And you know how ARC is so vibrant because of Chitra and a very well-renowned cataract and refractive surgeon as well. And Dr. J.K. Reddy, where is Dr. J.K. Reddy is there. Dr. J.K. Reddy is director of the Shankaraya Hospital, Coimbatore. He's a fantastic cataract and cornea surgeon, very innovative, lateral thinker, and he's going to give us inputs as well. Over to Dr. Ravi Shankar, the moderator, the court moderator, for the rules and regulations of this particular webinar, and then followed by the first speaker as well.
Vanakkam, Namaskar, and good morning to the entire galaxy of teams sitting in front of me. And court martial, as you know, as Dr. Mohan rightly said, we are virtual. So it's a different version of the regular court martial, not the usual style. Anyway, we have all the privilege and pleasure to get along with the program, and with due respects to the Supreme Judge and the honorary discipline, that is very important. And over to the first speaker. The court proceedings start.
Yeah, Ravi, I will tell
May I
you.
now call.
Ravi Shankar.
Yes, sir.
Please
Yes,
tell
sir.
the time limit for each speaker.
Tell me, sir.
Tell the time limit for each speaker.
Sure. I'll be telling you.
Yes.
On the rules and regulations, it is 4 minutes or less presentation by every speaker, and which will be followed by 8 minutes discussion. That is, the honorary jury will discuss on the particular case, and then the Supreme Judge would have his final decision. And the final decision by the Supreme Judge cannot be overruled or questioned by anybody. Supreme Judge kindly noted. And the first speaker would be Dr. Madana Gopal, a prolific vitreoretinal surgeon, a wonderful cataract surgeon too, hailing from doing his practice in Coimbatore, and shuttles to E Road on and off with his work. Dynamic person, and works very well on vitreoretina and has great ideas. And today, let us see whether he is Dr. Madana.
Thank you, sir. Thank you for the opportunity. I hope I'm audible. Shall I start, sir?
Yes, Madra.
Meeting.
Very good morning, TNOA office bearers, Supreme Judge, members of the jury, public prosecutor, court moderator, and esteemed viewers. I'll be presenting a case of ocular trauma, which had more than one pathology. In trauma, one has to be prepared for surprises and prioritize what cannot be compromised. So that is the learning that I took out of this particular case. So to begin with, this was a 20-year-old gentleman who presented with a firecracker injury. Open globe injury repair was done about a week ago before he presented to me. So that is the corneal wound that was sutured. He had iridodialysis for 5 clock hours and zonal dialysis for about 3 to 4 clock hours. And to top it all, there was a retinal detachment also. So I was effectively dealing with 3 problems at once. In this eye, which had post open globe injury repair, I was dealing with iridodialysis, zonal dialysis, and retinal detachment. Let's go to the surgery. To begin with, I started off with iridodialysis repair. You can see the temporal large iridodialysis. I made 2 partial thickness scleral flaps to place the iridodialysis sutures. So the flaps are placed in the area of iridodialysis. Once the flaps are made, a stab incision is made in the opposite meridian to help with the suture placement. I use a 26 gauge bent needle, 10-O proline. Using the railroad technique, it's very important to capture the iris at its base and not in the middle or at the pupillary margin where you can distort things. You can distort the pupil and make the whole surgery pointless. It's also important to be very gentle because this iris was very fragile and you could avulse everything from the root. And again, the surgery becomes pointless. So after placing the first suture, you can see that the pupil is okay, but there is still a gap temporarily. So I have to place a second suture as well. Now I begin to place the second suture again by the railroad technique. It's very important to remember that the instruments have to be gently handled because you're dealing with a clear lens. I wanted to retain the lens and have some kind of a barrier between the anterior and posterior segment because RD would also have to be settled with a tamponade. So you would not want the oil to come into the anterior segment. So the second suture was placed. You see that the hydrodialysis is well managed. Now I'm going ahead with the posterior segment work. Until this point, the lens was stable. So I didn't want to disturb the lens. As you see, the lens is stable at this point. So I go ahead and start my vitrectomy to remove vitreous hemorrhage. That is where the things began to wobble a little. You see that the lens began to tilt posteriorly. The equator begins to become visible as the formed vitreous. That's the retinal detachment with the break there temporarily. So in the middle of surgery, I really had no choice but to sacrifice the lens. So with a 23 gauge cutter, I went ahead and did a lensectomy, tried to preserve the anterior capsule, but nothing much came out of it. So once the lensectomy was performed, the whole eye became a single chamber. The anterior and posterior chamber segments were not divided by any barrier. And that's something that you actually don't want when doing an RD surgery like this. The breaks were marked with cautery. You can see that large break temporarily.
Can you be a little louder?
Audible now, sir?
Yeah, better.
Yeah, so the fluid air exchange was done, localized barrage, and the retina was well settled. Once I settled the retina, oil was used for tamponade, and now we remember that this is a eye with a single chamber, so oil came into the anterior segment. That was the unintended consequence of lensectomy. I had to make an inferior PA there with 23 gauge cutter, and then formed the AC with saline, sending the oil back into the posterior chamber. And then all wounds were, of course, sutured with 7/0 Vicryl. So that was the surgery. In this surgery, the tricky part was lens management. I wanted to retain the lens as one, this was a 20-year-old gentleman, and two, because the eye is going to be oil filled, you like the oil not to come into the AC. One possible option that I could have used is I could have gone for lens aspiration, IOL, and CTR, or a ring segment with an SFIOL backup. Now, what that does is it makes an already complex surgery more complex. I wanted to avoid that. Next option, I could have done the anterior segment surgery first and then gone for an RD repair later, given that this was not a total RD. But then that makes the number of surgeries 4 if you include SOR. So with all these in mind, I plan to leave the lens as such and deal with the iris and retina alone, hoping that the lens would not disturb me. In hindsight, that proved to be a mistake, which in my opinion was managed in the best possible way on table. In my defense, I would say that the lens can be replaced any day, not the iris or the retina. With that, I rest my case. Thank you. Thank you for patient audience and the opportunity.
Thank you, Dr. Madana Gopal. You are a son-in-law of a top ophthalmologist from Salem, nephew of the president of the TNOA. So your genes cannot go wrong. But I want to ask you why you didn't do a phaco, IOL, hydrodialysis repair, and then went inside, go inside and do a vitrectomy and attach the retina. Because that
True,
makes
sir.
a little more sense. And there's no question of more inflammation because you're doing all with small incisions. Especially when you have a patient with the 5 o'clock or zonal dialysis there, this patient, even if it's 20-year-old, definitely the patient is going like the lens is not going to be stable. So even if the lens is clear at that point of time, future the lens is likely to become cataractous. And a 5 o'clock or zonal dialysis, definitely it's going to make matters worse in the future. It's better to knock it off in the first, and better to leave them pseudophakic than aphakic, because that is going to give the best visual rehabilitation as far as the patient is concerned. So what I would suggest is probably a phaco, IOL, and zonal dialysis. You could have managed that with the CTR, and then probably the hydrodialysis repair, and then of course with sutureless vitrectomy, you could have gone in and attached the retina as well. That will be my line of management as far as this is concerned. That is definitely going to give better option as far as the visual rehabilitation for this particular patient is concerned. the patient is only 20, and even if the patient gets 624 or 618 vision, it's going to be definitely, now that you have made the patient aphakic, aphakic rehabilitation is going to be more difficult now for this patient. Now we go on to the jury members, starting from Dr. Sukumar and then Ramakrishnan. Quick one or two lines you can mention about this case. What would have done differently? Whether he is guilty or to be garlanded, that's a different issue. But I want your opinion. Or we can start either way. Nirmal, Chitra.
Yeah, yes, Dr. Mohan Rajan, Sir Judge, thank you. Of course, as you mentioned, this is a very young boy of 20 years old only. In that case, we have to do all the precautions and all the steps to at least save the lens, which is clear, or we should have planned to do something related to the lens implantation, whether it's iris claw, of course, not possible because of the hydrodialysis and all these things, but you can plan for your screening or something else. And also another important thing, how far this, because multiple procedure at the same time, no, will not be post-op inflammation and reaction, everything will be so great, so more. So that, whether it will be useful to do a step surgery, hydrodialysis repair and lens at a single setting, and then post-surgical detachment. And also the detachment, how long, how just, what about the retinal? You had a retinal dialysis or a tear or just a hole that you were not mentioned in the presentation. Because being a trauma, hello?
Yes,
Yes, sir, audible, sir. Please.
Yeah. Being a trauma, firecracker injury, that's why you should look like any other associated choroidal rupture or any macular involvement. All these things also you should look for, because it is a complex situation. Yeah.
yes, sir. I think the retinal tear looked big, sir. I don't know whether was it a dialysis, Madana? Yeah.
No, sir, it was a tear, sir. It was a tear.
Yeah,
Okay.
A larger tear, a large tear.
large tear. Nirmal.
Yes, sir. Madan, well handled, but I would like to differ on the way and the step. So, in multiple trauma, in a polytrauma situation with in a young patient with extensive injury to all the structures of the eye, it's not the number of surgeries that matter. It is the healing time you give for the patient to and the eye to recover. So I would agree with the public prosecutor, Dr. Mohan Rajan, in dealing the anterior segment first with a quieter eye take up for the retinal surgery later on. And patient would be well poised to undergo multiple procedure. And second, the other aspect I look at into the medico legal aspect. So you would have got consent for trauma for the globe repair and not for lens removal. So removing a lens in a young fellow like 20 years where you don't have a consent, so you have to go back and get his concern, explain that lens had to be removed with the situation. That makes the medico legal aspect bit complicated. So unless you have a open consent for lens removal. So how did you handle the legal process?
So valid point, sir, valid point. But in all these cases, my retinal consent includes a statement that aphakia is possible. Even if the patient has an IOL, many a time I would not have been the primary surgeon. The IOL looks stable on the slit lamp, but in practical experience, especially in trauma, we might have to go in. When you go in, the IOL will tilt. So my consent form always mentions that the lens or the IOL might have to be removed in order to address the main thing, that is the retina, and then the IOL can always be placed at a later date, and that is what my consent form always says.
Good. Chitra.
It was an amazing surgery, Dr. Madana Gopal. And it's just that because he's a 20-year-old, and it would have been very easy to have started off with a phacoemulsification, an iridodialysis repair, and then a retina procedure, all in the same sitting, because you're a very capable surgeon. Maybe that sequence would have worked out better, but finally, I'm sure your thought processes would have handled the visual rehabilitation too.
Absolutely right, Chitra. I think we would have gone that way, and there are different ways to skin the cat. And Sukumar, you would like to say something, Sukumar? Medical legal aspect. Sukumar, take a ready.
Sukumar has to unmute himself.
Unmute yourself.
Take a ready.
Hello?
Where is
Yeah.
JK?
Yes, sir. Audible. Yeah.
Yes, sir.
Madan has a little misjudged the situation, and as the other panelists opined, I am also of the opinion anti-segment could have been handled, then taken up post-segment. Then this problem of silicon oil coming into the anti-segment and aphakia could have been easily avoided. But anyway, he managed excellent in such a complex case at the end, and he did his best, and the patient hope he will do very well.
I think the
SFA has been kept.
Yes, sir. After a few months, this was actually last year's Diwali case. So after a few months, oil removal, anyway, oil removal was the second surgery. SFA was placed. So he had 618 or something. Macro was good. The defective version was because of the corneal wound that was sutured in the
ultimately it has been well managed, Madana Gopal, but you have done it well. Only thing is, and when you have a polytrauma, as Nirmal was rightly telling, I think we should take the consent form for everything, because anything can go wrong on the table. I would try to preserve the lens as much as possible. As much as that will be my primary aim. And even if I want to do 2 or 3 surgeries for that patient, I don't mind, but I want to preserve the lens. Because pseudophakic, definitely rehabilitation will be much better than the aphakic rehabilitation. Over to the final comments by the Supreme Judge, Siddharthan.
Thank you. This patient seems to have all the dialysis except renal dialysis. Okay. So, in the presence of zonal dialysis, do you think a primary IOL implantation is a good choice? Even if it is a scleral fixated IOL, maybe what you have ultimately done or doing a second scleral fixated IOL subsequently has yielded equally good results. So that's quite a good news to understand. That is another possibility also. And just one more caution I would like you to note, not only in this, even future, when you mentioned about the fluid that is being used in the eye, never mention saline, because that is gone and it could be recorded and placed against you. Always use the term BSS or balanced salt solution. Just a caution. Like our generation, we are used to that saline thing coming up that we have forgotten now. So as a young man, you should never think of saline. Okay, just take a caution on that. Thank you.
Absolutely, sir. I think BSS is the way to go, and even if you are going to use saline, don't mention that saline. Always use BSS. See, to Supreme Judge's comment, I think we can fix up a zonal dialysis, and about 4 or 5 clock hours only. We can fix it with the CTR in this particular patient, or even a Sioni or a Ahmed segment, and that's possible. And the lens will be quite stable because it's a traumatic, and it's not a progressive zonulopathy. So I think the pseudophakic rehabilitation would have been the better way to go. But ultimately, the result has been very good. Madana Gopal, as you know, is a good anterior as well as posterior segment surgeon. Hats off to you, Madana Gopal, and you can garland yourself.
Here.
Supreme Judge, tell him to garland himself. He's got the noose ready. What is it?
garland, sir.
Like noose.
Both.
That looks like a pavada, man.
Thank you. Thank
Over to
you.
the second speaker. Ravi. Ravi Shankar.
Ravi, you need to unmute yourself.
Thank you. Sorry about that. And
Start a video.
the second case presenter of the day is Dr. Kavita Kalevani. Kavita Kalevani is a prolific surgeon, cataract and pediatric department in well-renowned Sanka Nethralaya, Chennai. and she's very active in most of the continuing medical education programs in Chennai, Tamil Nadu, and all India, and a very good dynamic surgeon. May I have Dr. Kavita Kalevani to present and rest your case.
Thank
you, sir. Thank you for your kind words. After Madana Gopal's challenging, extraordinary case, I am actually presenting a set of 3 situations, but similar situations, which was managed in pediatric trauma. So this is my presentation.
Traumatic pediatric cataracts can have varied manifestations and involve multiple structures in the eye. Here are a few cases of post-traumatic cataracts with extensive iris involvement. Coming to individual case scenarios, this is a 1-year-old child, a case of battered baby syndrome. It was noticed that the iris was stretched and adhered to the cornea with no pupil or hence, a pupilloplasty is being done to create a visual axis. A total cataract was then encountered, which is extracted. On closure, a good red glow is seen and a well-centered pupil has been created. Coming to the case of a 4-year-old child with history of an old knife injury, he has a dense central corneal scar with minimal iris adhesion to the scar and an obliterated pupil. After creating a viable surgical field, a membranectomy with lens aspiration is done. Lastly, with the help of a vitrector, a pupilloplasty is done. The last scenario is that of a 6-year-old post-blunt trauma with a cataract and an iridodialysis. The cataract is managed first, as shown here, by lens aspiration with intraocular lens implantation in the sulcus. We then prepare the iridodialysis by the mechanical suturing technique. The anterior chamber is formed and the wound is closed. Hence, the take-home message is that concurrent management of iris-related issues helps reconstruct the anterior segment following trauma. Thank you all for watching.
Thank you, Kavita. Wonderful videos. Regarding the first case, I want to know, a 1-year-old child who did a traumatic cataract, battered baby syndrome, which is then what you can imagine. Battered baby syndrome, you have to have an eye index of suspicion. And as you must have seen a lot of Kavita Kalevani, as you know, is from a big institute, Shankar Nethralaya, where they do a lot of psychiatric work as well. I want to know whether the first case, the 1-year-old, did a posterior capsulorhexis for that patient.
Yes, because we had to remove the entire lens, leaving a rim of the posterior capsule in hope of future implantation, possible implantation of IOL in the sulcus. But the first setting, yes, we removed the anterior posterior capsule as well, along with the cataract. It was like a lensectomy with a retaining of the rim of the capsule.
Why you didn't implant a lens in this case?
It was a 1-year-old child. DBR was not done in the view of, we were not sure, because when before the surgery we had the entire pupil, we could not even, there was no anterior chamber. It was kind of adherent to the, not adherent, it was approximated to the cornea, and we had to kind of do an EUA, assess the situation and plan accordingly. So we didn't anticipate.
DBR for the fellow eye, no?
We routinely do not recommend and we do not do
Fellow
that.
was normal, I suppose.
Fellow is normal, yes.
No, you have left the child aphakic
Yes.
again. Okay, you left the child like the first case what you have done, what Madan has done. You left the child aphakic. So aphakic rehabilitation for 1 year child. I thought you can put the primary implantation. Could have done the primary implantation in this child.
I, sir, definitely would not advocate a primary IOL implantation, even if this was not a traumatic cataract, because the corneal diameter, axial length. Now, this was managed about 3-4 years back, but now we kind of relaxed the primary IOL implantation age to approximately 1 year or sometimes even less. But during those times, 2 years was considered as a safe age for primary IOL implantation.
That is exactly the reason why I asked you, because 1 year nowadays everybody is implanting unless the corneal diameter is less than 10.5. Yeah, okay, but that's the reason why I asked you, because we could have.
Bag was not the integrity of the bag was not maintained. So even if we plan to implant an IOL, I would prefer in a 1-year-old child implantation in the bag rather than in the sulcus, because onset of glaucoma. In fact, this child after 6 months ended up with a very bad glaucoma and had to have an Ahmed valve implant and all that. So I kind of
In the second case, why you didn't think of a pars plana membranectomy?
the rest of the retina and all was normal, sir. The posterior segment otherwise was normal. And until his approach, we planned an IOL implantation primarily. So preferred an anterior approach.
Second case, where the patient had a dense corneal scar.
Yes, sir.
So we owe to the jury, starting from Dr. J.K. Reddy. How different you manage this case?
Very difficult cases. She managed very well. But the second case, the corneal scar, there is a little bit cornea, clear cornea in the superiorly. She did a pupiloplasty and closed that also. So patient won't get any vision or any view also. Even for surgeon to see post-operatively, it becomes very difficult. So I could have deferred pupiloplasty in this case and allowed the pupil to go up so that we can see through the clear cornea. And they do very well. As you are telling, the implants, pseudophakic, they do very well. Why they deferred this one? Otherwise, excellently managed. Very, very difficult cases. These small children with injuries, very nicely done.
Yeah. Thank you, JK and Chitra. Please unmute yourself.
Very difficult cases, very well done. And of course, like Mohan, I thought, let me not get repetitive because he has discussed it in detail. I was little for an IOL implant right in the first sitting. Of course, later you said about the glaucoma issues. It was a battered baby, maybe a not well taken care. Some of these situations are best handled in the same sitting, no? I just wondered.
Based on that, because we didn't anticipate, we were not sure what we are handling with. Even IOP measurement, we couldn't get in the OPD. So all that we did on table. So he took a call and left the child aphakic and.
I know, but no, as a, as a pediatric ophthalmologist, you know better than everybody else. I think in a pediatric, it's like a Pandora's box. You could anticipate everything. It's like an abdomen laparotomy. When you open, it's like a temple of surprises. Similarly, in a pediatric cataract or anything, on the table you assess and take a lot of decisions, and probably take the consent for these patients that I will do this in case of a scenario like this. And over to Dr. Nirmal, what exactly you have done in this?
In my opinion, I think she's done better pupiloplasty for both cases and well managed. And for the 1-year child, I think it's always better for the eye to recover and also consider secondary IOL maybe after the child attains 2 years or 3 years when comfortable with general anesthesia or second procedure. And I also we have given some hope for it to recover from the injury, and also the infection rates are very high when you are in a initial such mixed trauma setting. So I think well managed case. Congratulations.
Thank you, sir.
Ramakrishnan, sir.
Thank you, Dr. Kavita, for a nice series of cases managed very well. I have only third that case, hydrodialysis with cataract. manage cataract first, then you were hydrodialysis. But usually in cases like that, what we normally do, repair the hydrodialysis first, so that any intraoperative maneuver when you do during cataract, it will increase the amount of hydrodialysis. So better to that too in a phakic eye. It's easy. In a pseudophakic air or phakic eye, difficult to put the suture and everything. So why you did like that? First you did the cataract, then you repair the hydrodialysis.
I agree with you, sir. Probably it could have been managed the other way also, but I thought a more stable, cataract surgery in that particular situation is kind of more important. So hydrodialysis repair is a more manipulative surgery. I prefer to do a cataract surgery, have an IOL safely placed, and then I thought once the pupil comes back to its original position to do an hydrodialysis repair. But I agree with you, sir. I could have done the other way also.
Yeah, because your view also will be obscured. Suppose there is a grass hydrodialysis, people will be in the iris will be the center. You will not be able to lens the cataract is easy. Yeah.
Yes.
Thank you.
Kumar, would you like to say something? Kumar, please unmute yourself.
Yeah. No, the only for that 1-year-old child, she could have waited for the IOL. That was the only thing, but the work was very fantastic. Really very good.
I think the new what do you call protocols as far as the pediatric IOL is concerned is they are starting even from the age of 6 months. They're doing IOL implantation. They're not waiting because the aphakic rehabilitation is becoming very, very difficult in these children. I do not know what Kavita thinks about it, but at least in my experience, I found out that primary implantation and in one go, trying to put a lens in the bag, then to put a lens in the sulcus, and for the lifelong 70 years, this child is going to be there. And if we're going to put a lens in the sulcus, imagine what is going to happen. If you don't have a lens in the bag, primary sitting, probably that will be definitely better than lens in the sulcus. Yes, Kavita.
I agree with you, sir. But this particular child, the bag and all was not at all integrity was not there, sir. It was a total membranous anterior capsule, and PC was membranous. We had to kind of create a visual axis actually and see if retina status. Nothing we knew before we had to take a we had to go step by step. So IOL definitely was not in my mind.
Okay, Kavita. Thanks a lot for the wonderful videos. Nice management. Over to Supreme Judge, Dr. Siddharthan.
Dr. Kavita, very, very challenging cases, well managed. And just one comment on a lighter vein. You said take home message. I'm already at home. I don't know where else to take this to.
Keep home message. Thank you.
And Supreme Judge, what's your verdict on Kavita?
He is in a good mood, so only garlands today.
Only garlands today, absolutely. So Kavita, you can garland yourself.
I don't know if this, I could only find this, sir.
Whatever you have, that's great, actually. Very good. Give her a big hand for Kavita.
Thank you.
Ravi Shankar, over to the third speaker.
Yes, thank you. And in the first case, we have a chat question which was answered in the chat by Dr. Madana. Dr. Badri Narayanan asked whether the macula was on or macula was completely off. And Dr. Madana has replied it was bisected. And thank you, Dr. Badri, for watching this program and asking the question. The next speaker of the day would be Dr. Karthik Srinivasan, a dynamic vitreoretinal surgeon, director, Aravind Eye Care System, Chennai. Works wonderfully the cases in Aravind, Chennai nowadays, and being in the family tradition with his wife around in the cornea department, does great work in Aravind, Chennai. Over to Dr. Karthik Srinivasan to rest this case.
Over to you, Karthik.
Sir, are you able to hear me, sir?
Yes, sir.
Yes, sir. I like to thank the TNOA at the offset for inviting me here. and the Honorable Supreme Judge and the jury and the prosecutor. And today I'll be presenting a case, a retina case today. So the whole point, that is the iatrogenic retinal breaks. So did I or did I not create an iatrogenic retinal break in this case? So that's what I want to prove. If you see the reference 1 that I'm showing here, people who try to make a hole always get paid for it. They get fame, they get money for it. And there are people also who try to make it in a different way. They don't go straight to the hole. And they also enjoy and are appreciated for making a hole. So these two references show that these people always enjoy making a hole. And as such, in retina case, the evidence that I'm showing you here, we sometimes create a hole in the posterior vitreous just to make sure that we remove the heme that is under at the beginning, so that we may look at the retina in a clearer manner, so that any fibrovascular proliferations or any tractional retinal detachments underneath the retina are clearly visible. So at this instance, for this case is a vitreous, complete vitreous hemorrhage with an extramacular TRD with hand movements vision in pseudophakia. And once you clear the heme, you're able to see the retina in a better manner, so that you may dissect the membranes easily, or you might cut the vitreous in a much more easier way. So this was, once this was completed, the next process of the complete core vitrectomy was done to remove all the vitreous from the vitreous cavity. And initially I thought that there was only extramacular TRD, and so the surgery was planned to have an oil instill in the site. So I would like to have the jury look at the nasal retina of this patient. The nasal retina is completely on, other than with sclerosed vessels that are present. So once this was completed, I went ahead and did an endo laser for the branch retinal vein occlusion that was present for the vitreous hemorrhage. And once I started to have air under the globe, I wanted to infuse the infusion fluid inside. And the moment I put my flute needle inside, you can all see that there is a retinal detachment that is happening. So the retinal detachment was happening because of the infusion fluid, which had gone and hit the retina, and that created a retinal hole. So this is the retinal hole that has been created by the infusion fluid, and because of that, the detachment has happened. So now for people who missed it, to see it, this is the fluid flow, and that has created a detachment over there. Then I had to manage this by first injecting air in the upper temporal half, so that the retinal detachment settles down a little bit. And once this was done, then I filled in perfluorocarbon liquid at the posterior pole to push the fluid from the posterior pole to the anterior part, and then remove the fluid from under the retina. So once this was done, I added a little more endo laser, and then removed the PFCL from the posterior segment by using a flute needle. So after doing this, to complete the case, then I injected oil into the globe because there is a detachment that was present. And once silicone oil was injected, the retina settled. So the whole point, the iatrogenic retinal break caused by an infusion fluid flow of a 25 gauge pars plana vitrectomy system is usually caused by an infusion fluid flow. And what was planned was a vitrectomy with oil, so that is what I executed. So hereby I rest my case. So this is a case of an iatrogenic retinal break, which was not intended to be done. And I will ask the jury to say their. Thank you.
Well done, Karthik. And Karthik, as you know, comes from a family of ophthalmologists. And both his parents are leading ophthalmologists in Aravind Eye Care system. And Karthik, I want to know the infusion fluid. What is the pressure of the infusion fluid coming inside? Number one. Number two, which part of the retina detached? It was the same part of the retina where the branch retinal vein was there.
So the first question, the infusion pressure was maintained at 30 with a flow of 30, sir. And the detachment happened at the sclerosed vessels area. So there was a hemiretinal vein occlusion, which was both on the nasal side and on the temporal side, the superior aspect. So the detachment has occurred. Maybe there was ischemia there. Maybe the retina was thin in that area. So that may be the cause that it had happened.
The hemiretinal vein has produced ischemia and probably thinned out retina in that area. That has caused the retinal break because of the force of the infusion fluid. The first time ever I have seen something like this, wherein infusion fluid is pretty. So, what are the precautions you will take to prevent this?
So precautions generally, sir. So if you look at the video, the infusion fluid, which was usually when you're under air, you'll have to use your machine to switch on the infusion fluid. So when the infusion fluid is under air, when you fill it up, the jet, when you want to do it, you can do it in a lower pressure, like I say around 15 to 20 millimeters IOP, if your machine allows that. So that will be a preventive measure. The second one would be to use a valved cannula. So valved cannula will help you to maintain the chamber stability so that there is no sudden hypotonia.
Also, because you have done some fairly good amount of vitrectomy before you did the fluid garage, you have done a good amount of vitrectomy.
Yes, sir. I usually, because this case, I wanted to spare another surgery and leave the patient filled with the BSS in the vitreous cavity and not fill with the oil than what I had planned for. I had to shave the base completely. So complete vitrectomy was done because there is some amount of blood that is stuck onto the pars plana area. So that was completely removed. And when that was done, only then I went ahead with the lasers.
I will tell you, I had one case of Osidex in a vitrectomized eye. When I put the Osidex, it produced a retinal tear. Because the Osidex went straight away and hit the retina. Have you seen this happen in your experience?
No, sir. Post vitrectomized eye, Osidex hitting the retina, never seen, sir.
Okay. We'll take on to the jury. Yes, sir.
By just putting the oil, the detachment settled.
Yes, sir.
Sir, I didn't get you, sir. You
No,
repeat the question.
just you put the oil, so the detachment settled, you said.
Yes, sir.
Just by putting the oil, the detachment got settled.
Yes, sir. Post oil, retina got completely settled.
Okay.
Chitra, I would like to say something.
Nothing different. Very well managed case, Dr. Karthik. I suppose these situations do come up, and if you're a capable surgeon like you, then I'm sure you have dealt with it as well as you could.
Thank you, ma'am.
I think well managed, Dr. Karthik. I think that is the shortest retinal detachment created and treated. That goes as a history rather. Yes, ischemia and pre-existing retinal lesions can induce because of the inflow as well as changes in the pressure inside the eye. And quite well managed because we were able to identify early, and even though the iatrogenic RD was created, it was treated in the same setting by early identification and good management. Well done.
Thank you, sir.
Very well done, Karthik. And JK, you'd like to say something? JK Ramakrishnan, sir?
Yeah, thank you, Karthik. It's a nicely managed the case. And one basic question, vitreous hemorrhage in BRVO, how often you will get? And also in this case, how long you have waited to do after the onset of vitreous hemorrhage?
Sir, the patient's history for defective vision is around 6 months, sir. Generally, for BRVO with vitreous hemorrhage, chronic vitreous hemorrhage, only then we will take it up for surgery. If it is going to be, say, less than 3 months, we don't take it up for surgery immediately unless and until it is the only seeing eye. So we generally are going for a sectoral panretinal photocoagulation to reduce the ischemia and then wait for the vitreous hemorrhage to resolve. This case, vitreous hemorrhage, we are seeing quite a number of patients who come with occlusion with vitreous hemorrhage in the population, sir.
So your diagnosis of BRVO is during vitrectomy or before?
Post vitrectomy, sir. Post vitrectomy.
Was there any you have missed any other cause?
Unlikely, sir. Patients are diabetic and are hypertensive. The vitreous hemorrhage was complete. We were not able to see the posterior pole at all.
Okay.
Any PRP was done before the Prior to that?
No, sir. No view of the fundus. So we were unable to comment on that. So only after the vitrectomy was done, we were able to see the posterior pole.
But you were not able to see any PRP marks done earlier.
No, sir. No. It was clear.
PRP
virgin
was
fundus.
done on the table.
On the table, sir.
The laser was done on the table.
On the table.
On the table.
When was the surgery done?
Surgery was done October 1st, sir.
Okay. Was it a post-COVID patient? Because we tend to see a lot of occlusive diseases in the post-COVID period.
Sir, she gave a history of 6 months, sir, from October. So maybe around the month of March or something, she had difficulty in vision. But because of the COVID time, she was not able to come to the hospital to get it done.
Okay. So maybe the long-standing hemorrhage and retinal inflammation would have caused.
Yes.
I am not sure whether we can, we want to wait, especially when the results of vitrectomy is very good, whether you want to wait for a long time for a vitreous hemorrhage, especially in a BRV. More than 2-3 months, I would not wait, because underlying retina is likely to be ischemic and thin, and this is what is going to happen. Okay. Karthik, I want your opinion. Madan is also there. Madan, I also want your opinion. And before we go on to the Supreme Judge.
Sir, with the newer practicalities, newer machines and newer cutters that we have, it is very easy to give them and rehabilitation of vision much quicker than what it used to be before. So our preference would be to advise them to get the surgery done as fast as possible, as quicker as possible, for them to go back to their lives. And it all depends on the patient's point of view also, sir. Whether they are financially stable to undergo the surgery, whether they have their there are a lot of other factors play, but we would like to get it done as early as possible.
That is right. You don't want to wait for 6 months at least. Madan?
No, sir.
True, sir. I would agree with whatever Karthik sir said, sir. I would go for an early one as much as possible.
Early surgery, probably because you don't want to have this ischemic component also.
Yes, sir. We have seen a lot of people go in for neovascular glaucoma. We've seen a lot of people who go in for absolute glaucoma. So we don't want that to happen. So we want to treat the lesion, treat the ischemia better by doing an endo laser if the pan-retinal photocoagulation sectoral is not possible because of the view.
And this is also a hemiretinal vein, not a BRVO.
No, sir. This is a hemiretinal.
It's equivalent to a CRVO, hemiretinal.
Yes,
yes. Absolutely. I think you should give a big round of applause to Karthik. Over to Supreme Judge.
Just one question with relation to what Mohan had asked about the pre-surgical PRP. Now,
yes.
I just want to know is if there had been a very deep scar because of PRP.
That is what I asked.
Can this jet produce this iatrogenic break?
Sir, as far as my experience and my limited experience is concerned, generally we have these silicone oil removal that we do. We generally do a fluid air exchange to completely remove any emulsified oil that is there in the posterior cavity multiple times. So each and every time we have the jet of infusion fluid coming into the posterior cavity when the cavity is filled with air. So this is my first case that I have seen when that has induced. But until now, for the last 12 years that I have been, I have not seen a jet of fluid coming and hitting the retina.
Thank you.
No, because the reason exactly what I asked that question, Karthik, is that because we have heavy burns, and the edge of that heavy burn, sometimes you see rheumatogenic RDs also. When you do a laser barrage, at the edge of that burns, you see breaks developing. At the edge of the cryoatrophy, you see breaks developing. It's a little heavy. So that is the reason why I asked whether PRP was been done earlier.
Yes, sir.
Yeah.
So this was a virgin retina, sir. No PRP was done.
No PRP was done. Okay. Supreme Judge, what's your verdict?
It's a very interesting presentation, and I could learn quite a lot from this. Well done.
Thank you, sir.
Self-garland.
Garland yourself.
Right, sir. Thank you, sir. Thank you very much.
That's the garland.
Sir, garland is not...
Ask Divya to garland you.
Right, sir. Okay, sir.
Over to next speaker.
Thank you, sir. And Supreme Judge, please note, henceforth, Dr. Karthik Srinivasan will be called a holy surgeon. H-O-L-E-Y. Over to the next presenter of the day.
H-O-L-Y.
Continuing the...
H-O-L-Y.
Yes, sir.
Holy.
That's what I meant, sir, but it was double-edged, H-O-L-E-Y. Thank you, sir. Thank you. And the next speaker of the day, continuing the legendary legacy of his father, Dr. Ramakrishnan, dynamic cataract and refractive surgeon who's head of the department, Aravind Pondicherry, in the cataract and IOL, and always willing to come and present his cases in any platform. Over to Dr. Vivek Ramakrishnan.
Good morning, everybody. I would like to thank Ravi Shankar sir and Mohan Rajan sir for giving me this opportunity. So this is a hard mature cataract where direct chop, the first chop went very well. And I wanted to do a 180-degree rotation for the second chop. Since the hold was not proper, the chop was incomplete. And then on the left, you could see the zonules breaking because of the hardness of the nucleus and the pressure. So in this case, what I decided to do was, instead of converting, I thought I will place capsular hooks, complete the phacoemulsification, place a CTR, and then place a CTS. That was the idea. And as usual, when we are emulsifying the last quadrant, when there is no epinucleus or cortical support, chances of having a PCR is high. Now you can see the PCR happening. So I had no choice but to convert it to a sclerocorneal tunnel. So the clear corneal incision was extended posteriorly into the sclera on either side to create a frown-like incision. And then a sclerocorneal tunnel was constructed. A keratometry was done to extend the wound instead of doing an extra cap to leave the surgery sutureless. And then this was the picture. So with the anterior vitrectomy machine, the anterior lens capsule, one half of the anterior lens capsule, which had the zonular dialysis, was removed along with the vitreous. So this was what I was left with. So instead of leaving the patient aphakic or going for an iris claw lens or doing a secondary IOL later, I had other plans. So since 6 clock hours of support was available, I intended to do a single haptic iris fixation using a 10-0 Prolene suture with a long curved needle. A bite was taken so that it passes the mid-periphery of the iris and not the pupillary margin nor the equator, so as to have proper centration. And then I made a paracentesis right in between the two bites, so as to, this paracentesis actually helps in externalizing the suture at the end and tying the knot. A gentle tap on the iris pushes the suture down, and it helps in retrieval of the suture through the main tunnel, which I've a sclerocorneal tunnel. The suture loop is then looped around the haptic a couple of times. And once the looping is done, to make sure that the loops do not slip away, the loops are pushed. And then once it is ready for loading into the eye, the sutures are tightened so that it is not loose over the haptic. It is pulled in such a way that it kind of constricts the, holds on to the haptic very firmly. It is done again to ensure that the sutures do not slip away. And then instead of dialing the IOL, it is always important that we place the IOL by pronating the haptic. And then using a Sinskey's hook, after trimming the sutures externally, the Sinskey's hook kind of pulls the IOL suture into the anterior chamber, and with the help of a Kuglen's hook, it is externalized through the paracentesis. Likewise, the other suture is also externalized to the common paracentesis. So once it is externalized through the common paracentesis, the suture is then tied. Usually take three loops for the first bite. And it is tied in such a way that it does not crush the iris tissue. So it is tied according to the, so it is very important to observe how much tilt the IOL has while tying the suture. So the IOL tilt was, as long as we can see with the naked eye, it is flat. And then after the suturing is done, the suture is trimmed. And then the suture is pushed inside the anterior chamber. And remaining viscoelastic is removed. If any vitreous stand is there, vitrectomy is done. A pilomen is used to constrict. The main advantage of this procedure is that pupillary constriction does not get affected. Pupillary dilatation postoperatively can be done. And this was the end of surgery. Thank you.
Thank you, Vivek, for the wonderful management. You started off with a mature cataract and with the zonular dialysis there, and then you used capsular hooks. And subsequently, you had a PCR. Am I right?
Yes, sir. Yes.
Okay. The only thing is, when you had a PCR, you extended the incision. You have removed the capsular bag. You have done the vitrectomy through the same port. You had the irrigation and the aspiration. That is a cutter in the same port. You have not used tricot. I don't know. How do you know whether you have removed the vitreous? So these are the 2-3 points I would write. And to make the complications, that is the matters worse, why unnecessarily put a sutured lens into the skin when you can just put a iris fixation? It's a very simple matter. You just have to go retrofixate the iris, and anyway you are planning to fix a lens on the back surface of the iris. So iris fixation would have been definitely a better option than putting a suture multi-piece lens, and because it's going to little longer procedure as well. And I want to know what exactly you want to say on these things.
The inflammation post-operatively is very minimal in iris sutured compared to iris claw, because the suture does not crush the iris tissue. It is a little bit let loose over the iris. So the only point of contact for the suture would be the 2 points piercing the iris. That is one point. And since there is capsular support, very strong capsular support, 6 clock hours, we do not have to go for a specially designed IOL. So this can be done easily with any 3-piece IOL available with us. And all we need is just a Kuglen hook and a 10-0 Prolene suture.
What about UGH syndrome? Because every time the iris goes up and down, okay, dilates and constricts, it's on contact with the surface of the optic. The optic is also in touch with to a certain extent.
A little bit, no, sir. It is not as close. If we observe post-operatively, most of the time it gets discharged as a PCIOL patient, because we do not tighten the suture much. It is a little bit hanging low, like the sulcus placement, normal sulcus placement in the same depth. So we have to visualize that during surgery and then tighten the suture. So it does not touch the optic at all. And pupillary dilatation is not a problem post-operatively. You can have a full dilatation, whereas in iris claw, sometimes there is a restriction of pupillary movement and there is a lot of pigment release. In this sutured IFIOLs, it is very less comparative.
Yeah. Why you didn't use tricot for a vitrectomy, anti-vitrectomy?
I could see clearly, sir. We could have used, but it was clear. We did a very extensive anterior vitrectomy.
Nobody can see vitreous clearly.
Yes.
Eagle eye or something like that. Vitreous is a colorless substance.
Yes, sir. Yes, sir. Absolutely.
It's really available for you.
Yes, sir. Yes. And, next time I'll use it, sir.
Well. Go to Chitra.
Each of us have our own choices of doing surgeries, and we prefer that. So I would have thought of an iris claw and done it in no time. And I'm sure you could do that too. But just since most of the questions were well covered by Mohan Rajan, with the haptic suture to iris in one place and little falling back in the sulcus in the other, that minimal tilt is not in any way bothersome?
Madam, the tilt actually, what we appreciate, so when we are tightening the suture, so when we see it being flat over the iris, if any tilt will be appreciated. Probably very minimal tilt can be there, but we've done post-operative ASOCTs, and we found out single haptics are more stable than the double haptic fixing. Because the suture, it just depends on one suture. Double haptic, we have to have 2 sutures exactly at the same level. So this one has been better actually.
Amazing surgery. Very good.
Very nice. JK?
Yeah, very well managed. So many problems he had during the surgery, but very confidently and very nice, very well managed. And a very good job done. Nothing more to add.
Was there any astigmatism in this case, Vivek?
Sir, so the IOL placement was the sulcus placement power was placed. Post-operatively, 0.5 astigmatism was noted in this patient.
Only 0.5. How many days post-operative this case?
Sir, it's been almost 6 months now since we operated.
Do you have more incidence of iritis or the iris atrophic patches over the sutured areas?
Sir, with iris sutured IOLs, we have not seen much iritis. Sir, even on the post-operative day one, the iritis is actually very minimal if we do a proper vitrectomy and if we remove the viscoelastic properly. With iris club, we've seen a little bit of iritis.
I beg to differ. I think it's how the primary complication is handled, which is
Yes,
why
madam,
you
yes.
have. So with
Yes,
the
yes.
well-handled case, you could do any of the IOL implants and get away with it.
Yes, madam.
Dr. R.K. sir?
Yeah, it's a it's a nicely managed case, but I want to ask, during your maneuver in the initial stage, for doing cracking, so the force what you use is little, I feel it's more. I want to know whether you have done a good, again, such a hard cataract, you should have a nucleus. You should have done, I don't know, a good hydrodissection. Is it that was there? You did a good hydrodissection to prevent the stress on the zone. Because you told during maneuver only you had a zonal dialysis.
Yes, sir. The zonal dialysis actually was because of the hold on the nucleus was not proper. So it kind of mechanically, the chopper had to push it. I thought the hold was good because there was no space where I couldn't really assess how the hold was. So that was the reason for zonal dialysis.
What hooks did he
Yeah. Dr. Vivek?
Yes, sir.
Let me be honest. My VR experience is some 30 years old. Okay. So unless the patient wants a toric IOL or a multifocal IOL, I will, for these negro cataracts and red Indian cataracts, I would rather prefer an SICS, go home and sleep in peace.
Yes, sir. Yes, sir. Yes.
No, whatever cataract they being only. Namakarvala bochi.
Simple is always better.
Yes.
Actually, but one of the days now it is young blood and the technology is very supportive.
Also the Centurion
Doing
missions
innovative surgeries.
Missionary, yeah.
Supreme Tech.
Yeah, technology.
The young blood always think of high technology, no? Okay.
Thank you, and you can garland yourself, Dr. Vivek. Thank you. And over to the next speaker. Can I go to the next speaker of the day?
Yes.
The next speaker of the day hails from Tiruchirappalli, continuing the work from her father, Dr. Ramesh from Mahatma Eye Hospital, doing wonderful cataract and refractive surgery. Dr. Shruti has joined him doing great work. And over to Dr. Shruti Vaishali Ramesh.
Thank you, sir, for this wonderful opportunity. And good evening to the. Hello, sir. Am I audible, sir? Hello.
Very audible.
Yeah. Okay, sir. Thank you. So, good afternoon to the honorable judges, jury, and the prosecutors. So, I know that the posterior polar always poses a threat, and it always feels impossible until it's done. So, here's to conquering the poles. So posterior polar cataract, why is it an issue? Because we know that the problem lies in the posterior capsule, which is going to be dehiscent and gives away even with the minor level of turbulence in the anterior chamber. So what I did for this case is I went ahead with active fluidics, a very low intraoperative pressure, a good IOP ramp of 3 seconds, and which all ultimately helped me reducing the surge factor. So this was a 43-year-old male patient with a discoid polar cataract with a nucleosclerosis of grade 2. He was planned for a trifocal IOL implantation. So I started off the surgery with a good wound construction with a well-centered capsulorhexis and went ahead with an inside-out hydrodelineation, which was advantageous because I was able to leave the adequate amount of epinuclear cushion that was required for protecting the posterior capsule. And as you can see, my parameters were all well controlled with a low IOP of 26 millimeters of mercury and a controlled aspiration rate and the vacuum in a reverse linear mode. And following the hydrodelineation, I went ahead with eating the nucleus by creating a central bowl and using the blunt dissector to feed the fragments into the phaco probe. And as I advance in the surgery, I make sure that I step down on the phaco parameters by reducing the aspiration rate even less and reducing the vacuum so that there won't be any turbulence in the anterior chamber to prevent any fluctuation and causing PC stress. And I made sure that I always had the chamber formed by injecting viscoelastic before removing the irrigation. And we should make sure that we never overstress the capsule. And for removing the epinucleus, since it was already freed out, I used a blunt dissector to cleave a plane and remove the epinucleus from the bag and then go ahead and eat it with the phaco probe. And again, this was all done under very low intraoperative pressure, very low vacuum and aspiration, suggesting of a slow motion phaco. But even with all the meticulous planning and surgery, by the end of the last fragment removal, I noticed that there is a vertical split in the posterior capsule, almost extending from the equator to equator. So I immediately inject a dispersive OVD to prevent any vitreous prolapse. And I noticed that there is no disturbance of the anterior vitreous face. So I go ahead with doing a cortex wash with a bimanual IA and slowly peeling the cortex with in a very well controlled manner so as to not prevent any extension of the capsular rupture. So here, as I had planned for a trifocal implantation, the conundrum was whether to go ahead with that lens in the bag or a 3-piece IOL in the sulcus with a reverse optic capture. So I had 3 things in mind. I didn't want my IOL to get oriented along the PCR, or I didn't want an IOL tilting into the vitreous. I planned in such a way that the IOL oriented in 90 degree, the haptics were 90 degree to the PCR. And so what I did was I pushed the cartridge into the AC, not in a wound assisted fashion, so that I had a controlled injection of the leading haptic into the intact part of the bag. And I made sure that I never dialed the intraocular lens at any part in time, and kept on making small nudging movements so that it went ahead and placed itself well centered in the bag without disturbing the posterior capsular end. And this was all done after putting in dispersive OVD so that the vitreous wouldn't be disturbed at any point. And here you can see a well centered IOL with a 360-degree overlap of the anterior capsular rhexis, and the posterior end did not extend. And I just washed the visco with saline. And I made sure that even while irrigating the wound, I did not overpressurize the chamber at any point, which could cause a disturbance in the vitreous. And this was the 1-week follow-up of the patient. The patient came back very happy with a very well-centered IOL and an uncorrected visual acuity of 6.6 and N6. Thank you.
Okay, Dr. Shruti, well managed.
Thank you, sir.
Posterior polar cataracts, we all know, are the most tricky and one among the most complicated surgeries everyone would have experienced in their life. It's not that easy to finish and give an outcome. But if Dr. Mohan was here, he would have said, he would have vouched that femto is the only way. But at the end of the day, people who do not have access to femto, how are they going to do? Over to Dr. Nirmal, please.
Thank you, Ravi. Well managed, Shruti, given the case with pre-existing. Did you do a OCT and see the posterior posterior look for any pre-existing tear or hole in the?
We didn't do an OCT, sir, but it was a very clear nucleus, so we were able to assess the integrity of the posterior capsule with the slit lamp biomicroscopy, sir.
Okay, so was that in order, or was there any dehiscence?
There was no pre-existing dehiscence, sir.
Okay, so that means during the procedure, the thin posterior capsule would have given way. And also, what is the purpose of putting in a multifocal IOL? Because sometimes the tear can extend postoperatively when the IOP rises. So, are you justified in putting a multifocal IOL if it can there can be tilt, or the lens can fall back? So even though it's a younger patient, so there is always a chance of multifocal being not in place.
Yes, sir. Actually, there was this mild confusion whether to go ahead with the multifocal lens or place a 3-piece lens in the sulcus. But given that the entire integrity of the bag was not compromised, the anterior capsule was intact and the rhexis was intact, and there was no disturbance in the anterior vitreous face. So with that in mind, and even when placing the IOL, we were able to assess whether the bag is going to be stable post-operatively or not. So we went ahead, and once I placed the IOL, I could see that the bag was stable. There was no tilting, there was no instability or a shaking of the IOL. So that was how we decided to go ahead.
good, Smriti. It's nicely managed, but in such a big rent, a single piece, I will usually we will defer. We usually normally go for a 3-piece.
Yes, sir.
Huh?
Yes, sir. Yes, sir.
Yeah.
Shruti, that was a very well managed case, and you discussed each step very beautifully, the whole dynamics. And of course, you did show that you did not stretch the bag, and how you placed the IOL, and how you even finally did not do too much of hydration, so that could also cause a stretch to the PC. But if you're not too sure, I think you can still do a multifocal, but you could do a 3-piece multifocal and do an optic capture and still get the best of results.
Yes, ma'am. Thank you, ma'am. I think that could have been planned. Yes, ma'am.
Yeah, single piece very difficult. Anything can happen with the single piece.
Yes, sir.
You never put a single piece. You will always go for 3-piece only.
Okay. Okay, sir. Sir. Ideally,
Thanks,
3-piece
Dr.
should have been
Subha.
placed,
Dr.
sir.
JK, your comment.
It's a well-managed case. In spite of so many surprises, such a young surgeon, it's very good to see the surgery by young ophthalmologist from Tamil Nadu. Such a nice, difficult case, well managed. As all opinion, my opinion also is multiple. It is such a big grant. Generally, better unless we counsel the patient, I have to do another surgery in case something happens. And multifocals are not really available. It's very difficult to get them, and very few companies are making. And no trifocal is available. That is the limitation. My preference would be in the monofocal 3-piece placing. As we go older, we try to be more safe.
Definitely, sir.
Young people always take some risk. They can afford.
Like Vivek, we shall.
Thank you, sir.
You've been bold by doing it. I think at the end of the day, never promise a patient with multifocal or any premium IOLs when you feel you're going to handle a posterior polar cataract, because the daily sense, as you said, Dr. Nirmal rightly pointed, did you do an ASOCT? Because whether you've seen a slit lamp, you identified, in spite of it, document with the ASOCT. Document the posterior segment very clearly, so that in case if there is a medical legal aspect in the later stage, it will definitely help you and support you. That's one point Dr. Nirmal has very clearly pointed. And never promise a patient for a multifocal or any premium. Just tell him I'll do my best job. I'm going to implant a multifocal. In any case, if I'm not able to do it, I'll be doing a unifocal. That's the way you need to deal with the patient prior touching the patient. Over to the Supreme Judge, Dr. Siddharthan, please.
Very nice presentation. The few things which I'd like to know. First thing is, some of the panelists or the judges could tell me which is the best way to assess the status of the posterior capsule prior to surgery for decisions. How do you?
I think ASOCT will help, and if the posterior the cataract is very thick, we can also use a B scan. So, but I think we have to properly do a B scan to assess the posterior capsule, and of course, clinical examination, due diligence, dilated with a dilated pupil, you can do.
So ASOCT is the mainstay, right?
Yeah.
Okay. Now the second thing is, see, as I have told you earlier, I am from the old school of thought. So my methods are totally not logical, but what I do is, I do what people say don't do. I do the hydrodissection. Now, if I notice the flow crossing over the polar cataract and moving away smoothly, I know there is no dehiscence. But if it stops here and goes around, I know it is attached to the posterior capsule, and I can expect a hole, especially in a young patient. So accordingly, I get prepared for vitrectomy and suitable lens and so on. The other thing is the multifocal lens, if you are placed in the bag, yes. Since there is a dehiscence in the posterior capsule. Now, this IOL power, I think, will not be in the exact predicted place. It's going to move. Then your calculation is going to go haywire. What do you think about this, JK?
I don't think so.
In sulcus, I put 0.5 diopters less power. If I put in the sulcus, I put 0.5 diopters less power. But not hydrophilics. It should be hydrophobic 3-piece. If you put a hydrophilic in the sulcus, it's very bizarre. Some people I saw using, but it's not a good idea.
Chitra.
An IOL in the back, as she has done, we don't have to change the biometry in that kind of a situation at all. Again, you don't have to change it if you're doing an optic capture. If placing it in the sulcus and not doing an optic capture alone, you have to change the biometry.
Okay, thank you.
Again, the message we should convey is always have a backup lens. And
right.
second, yeah, 3-piece lens is far better than a single-piece IOL in this context. And multifocal, I think I won't promise the patient unless we're very, very sure of having a 3-piece multifocal. So this case, I think the one problem with me personally is inserting a multifocal IOL with a large tear in place.
Sorry, I was not there. Shruti's case, is it?
Yes, sir.
Yeah. So you sent that this thing to me. So I have not seen the video, but I also will tend to agree with Nirmal that I would not put a multifocal when you have a large PC tear. And usually in PPC, it's like 2 pillars in the posterior capsule. And you cannot guarantee long-term stability of these lenses.
Exactly. And multifocal Acrosoft, it's a bit heavy lens also. So tend to stretch the capsule a bit.
No, yes, sir.
Go to are we finished with all the jury members?
Yes.
Go to Supreme Judge.
Supreme Judge முடிச்சிட்டார்.
I have finished.
எல்லாத்துக்கும் பயமுறியாது.
Finished.
Okay. So self garland.
Thank you.
Thank you, sir.
Shruti self garland.
Okay, sir.
Go to the next speaker, Ravi.
The next speaker, Dr. Shreesh Kumar Kadavur from the Eye Foundation, Coimbatore, head of the department cornea and refractive surgery at the Eye Foundation, and has been a very prolific cornea and refractive surgeon. Over to Dr. Shreesh Kumar. Shreesh, you can share your screen and rest you.
Thanks, Dr. Mohan Rajan and Dr. Ravi Shankar for this opportunity. So I'm going to show a case of DALK in healed eye drops. We all know management of keratoconus post eye drops scarred cornea is still controversial, and therefore surgical techniques of choice still remains debatable in these cases due to the pre-existent DM tear. So DALK is definitely preferred over PK because of the advantages over PK. However, DALK has a steep learning curve, and especially in the case of post-healed eye drops, where there is a pre-existent DM perforation, and chances of intraoperative extension of these stays is extremely common. So this is actually a case of healed eye drops. This is one of my old videos, more than 10 years, and I am attempting a DALK in this case. I have done a mistake of injecting air, which has ruptured the DM, and you can see the ACS collapse, and I'm repeatedly injecting air into the anterior chamber. Luckily, I could do a decent job. I could maintain the anterior chamber and do a DALK in this particular case, but I should not have injected air directly into the scarred area. So I could complete DALK in this case, and the patient did extremely well. This is the post-operative picture. This is 6 months. You can see a scarred cornea here, which is very well healed, and it is very well attached to the donor. And this is the scarred area, which is paracentral, not exactly in the center. And so the mistakes are lessons, and the mistakes have the power to turn you into something better than you were before. So this is another case. Nowadays, routinely I started doing DALK for these kind of cases. This is a case where there is a paracentral scar, and the visual acuity is 636 with the best of correction. And this is the anterior segment to OCT. You can see the scar notching here, and there is a surrounding corneal scar in the superficial and deep stroma. And this is a specular microscopic picture and topography of the same patient. I went ahead with the DALK. I inject air into stroma here to create emphysema away from the central scar. This I have learned after doing that first case, away from the central DM tear by a limited air injection into stroma. Something similar to what we do in hydrodissection for PPC, which is a limited hydrodissection. So this thickening of stroma due to formation of a multitude of layers of tiny bubbles facilitate stromal separation. And the surgical technique here is layer by layer dissection from the periphery. This is a centripetal dissection technique where the dissection is initially carried out at the periphery, and then moving gradually towards the center. And this helps in successful initial dissection of most of the healthy areas, and to prevent chances of initial antechamber perforations and collapse of the chamber. Thus, it prevents or ensures a successful DALK in pre-existing perforations. And one should not aim for big bubble in these cases. Here we aim for air-assisted manual dissection, and multiple bubbles give us a rough idea of the depth of dissection. And using a crescent blade and a lymph forceps, the dissection is carried out from the periphery to the center. The scarred area should be dissected last, and try to avoid perforation for optimal outcomes. Reaching decimates is desirable. However, in these cases, it is not possible to reach decimates. You can perform what is called a pre-decimatic DALK in these cases. So the perforation, the scarred area, hydrops area must be left until the end of the tissue removal, and a small amount of stromal tissue is also left there. So healed hydrops with the paracentral scars have done very well since then. And this is the same patient, the first day postoperative picture, and this is 6 weeks and 6 months. You can see a small scar, small defect in the descemetes, but it has not affected the visual acuity. You can attempt this in patients with the paracentral healed scars. This is the preoperative ASOCT, and this is the postoperative ASOCT. There is a small amount of scar here, but the visual acuity BCVA is very good in these cases. There are a few more cases I have done, and just to say, mistakes increase your experience, and experiences decrease your mistakes. And if you learn from your mistakes, then others can learn from your success. Thank you.
Thank you, Suresh, for the wonderful presentation. You have given all the parameters as far as DALK is concerned. DALK in healed eye drops is a well documented and is a standard. In fact, I would say Susan Jacob is advocating DALK in acute eye drops. What is your take on that? She has even published the paper in acute eye drops, DALK.
No, like I don't advise that. You can suture the tear and wait for some time for this to heal. Once it heals, once there is a scar, then you can go ahead and do a DALK in these cases. But in acute eye drops, so when the gap is so wide,
So in such cases, definitely if it is right in the center, definitely you should not do it. Maybe in the periphery or mid-periphery, or if it is a small tear, you can attempt, but if it is right in the center, if it is a large tear, we should not attempt.
I don't know whether you have seen our videos. It is really amazing to see your videos. But I always thought it was not a very good idea to do it in acute eye drops. I want the opinion of the jury members on this. JK?
Yeah. Always somebody has to try. Then only we learn. We can. I never like to say, to be frank, that somebody is doing wrong or somebody is doing. You should not do.
I'm not saying
I
that.
never say that. I never like that also. Somebody has to start and somebody has to do something. Either this is correct or wrong, time will tell. So I think what Susan is doing an excellent job now, right? Let her do it.
Yes.
Over a period of time, whether it is correct or not.
What is your opinion? I want to know.
It works very well. My opinion, I will do it. I will do it.
Even in acute eye drops, you will do it.
Yes, I will do it. Right now, I'm doing PK, but I think acute eye drops, I will, after seeing her, start doing the dark also.
Okay, Nirmal, Chitra?
Very well done, Shrish, and lot of learning from your case. And of course, I would also, the way you discussed it, I felt that a more conservative approach is advised, but then one person has to be experimental for new things to evolve. So there is a point to everything, but a well done case, and we are happy to see all these very interesting cases today.
We have no idea about this.
Suresh is a wonderful surgery, series of cases. Just basic, I want to know, with so much of dissection, no? Was there any chance of stromal haze in these cases post-operatively? Is there any role for mitomycin, something like that?
Somehow I have seen even in pre-decimatic darks and all, like I thought there will be a lot of scarring in the interface, but most of these cases will do very well. The BCVA will improve up to 6 parts in these cases. The chances of interface haze is much less as expected.
Good.
What is the explanation for that? Like if it was something involving the epithelium, there would be a haze. You have to deal with mitomycin.
Maybe these keratocytes are the density of keratocytes is much less in the posterior stroma. We are going to leave only the posterior stroma very close to descemetes. That could be the reason for less haze in these cases.
Probably you need to remove as much of the stroma as possible.
Yes.
So that is a key take-home message. What are the precautions you will take, J.K. Reddy, while doing DALK and acute eye drops?
As it is nothing, unless we will have a cornea, good cornea for PK in case necessary to convert. That's all. Otherwise, only thing is we are changing now more and more to mushroom grafts.
But that gap is there, no? In acute eye drops, there is a gap, as Sirish was rightly mentioning.
Yeah, the gap will be there, but generally anti-segment OCT is clearly showing in acute eye drops the cystic spaces in the stroma. It's anti-segment OCT revolutionizing the corneal diagnosis and management. So we can exactly see where is that break and how much is extended. So if the break is a really big one, then we can put a air before in the antechamber and go ahead and try. Like that we can plan. It is giving very good picture of what we are.
So probably intraoperative OCT, IOCT will be definitely.
That will be excellent, but we don't have that, most of us.
I know. Now I've seen some videos from Namrata also.
Yeah.
Really fantastic. Over to the Supreme Judge, Siddharthan.
Shrees, your appearance is very deceptive. You look so young, but you're performing so well as an experienced surgeon. Okay, now no comments on this because I don't use TALK on my face or DALK on somebody else's face.
Thank you, sir.
Whether he has to be hanged or garlanded, Siddharth.
Yeah.
Double garland.
Obvious. Self
Garland.
garland.
Thank you, sir. Thank you.
Self
Thank you.
garland.
I have it.
Ah,
Thank you,
beautiful
sir.
talent you have got.
Thank you.
Yeah, very nice. Very nicely done, Dalk, with a
He
lot
looks
of.
like a politician.
Thank you, sir. Thank you.
Absolutely. Thank you, Suresh, for participating in this.
Thank
And
you.
over to Ravi Shankar for the last speaker. I think we are on time.
Over to the last, and we are well ahead of time. It's great to finish at 1:50, 1:30. Very nice. Thank you, everyone, for cooperating so well and doing it in an excellent manner. Over to the next speaker. Our next speaker would be Dr. Vandana Sundaram, an associate at Shankara Eye Hospital, working with prolific, ever young look Dr. J.K. Reddy. And she'll be presenting this and resting in place for it. I think Dr. J.K. is keen to see and already advised her how she needs to present. Over to Dr. Vandana.
Thank you, sir. At the outset, I'd like to thank TNOA for this wonderful opportunity. So finishing the program, we actually have a medical case instead of a surgical case, but quite an interesting one. So I'll share my screen right now.
Please share your screen. Yeah.
Yes. Can you see it, sir?
Yes.
Yeah.
I'm not able to see the screen.
Not able to see the screen, sir?
Yeah. No, doctor.
Yeah,
He's using a sunscreen, I think.
Open your PowerPoint.
Yeah, it was working earlier, sir. So
Okay.
now I don't know on testing. Sorry.
Your backend and then click on share screen, ma'am. Otherwise, we can also share screen, entire screen.
Vandana, you just open the PowerPoint and minimize it and keep. Then put the share screen and then click on the PowerPoint. And there'll be a small share icon on the right bottom. You have to press that.
I'm sorry, it was working earlier while testing. 1 second.
Yes.
Maybe the phone you may have to switch off, or you have to log in again in the computer laptop.
I don't think she has to log in. She can stop sharing and share again. I think she knows it.
No, she did it in the beginning before we started the session. She shared the screen and checked it up. It was okay. Can somebody help her, Ravi?
Just a minute, sir.
Aarti.
I'm talking to her.
Yeah.
Aarti from the technical team is helping us.
Maybe she switched on. She
Anyway,
logged
this
on.
session is being sponsored by Lupin. For everybody, Lupin Blue.
Lupin Blue Eyes.
Tomorrow onwards, please write Lupin products.
Mohan, I'm sorry. I think I'll have to leave now. I would have loved to watch her case.
Just be for this case and go. No, it's not even 1 o'clock, Chitra.
65-year-old female patient was referred to our center with pain, redness, and watering of 1 week duration and a history of pterygium surgery 5 years back. BCVA was 612 in the involved eye, and patient was on tablet toxi, prednisolone eye drops, CMC eye drops, and tobramycin eye drops. On slit lamp examination, there was diffuse congestion with dilated episcleral vessels and a 4x4 mm area of scleral melt nasal to the cornea. The cornea was clear with a quiet anterior chamber. A provisional diagnosis of right eye scleral melt post-pterygium surgery was made, and patient was started on intensive lubricants along with tablet prednisolone in tapering doses. However, 1 week later, there was a vision drop to 3/16. And on examination, there was an alarming increase in the area of scleral melt, along with multiple pinpoint corneal stromal infiltrates extending from the mid-stroma to the deep stroma. Patient was also symptomatically worse. We thought we had gotten the right diagnosis, but in reality, we were just clean bowled. But why the sudden worsening? What could be the cause? Is it due to a rebound inflammation after stopping topical steroids? Or is stronger immunosuppression needed? Or do we even have the right diagnosis? Our next plan of action was systemic investigations to rule out autoimmune conditions and a routine scraping prior to starting immunosuppression, along with a rheumatologist opinion prior to starting cyclophosphamide. We had a big surprise in store. 48 hours later, vision dropped down to hand movements, and there was an increase in the corneal stromal infiltrates, along with low-grade vitritis. And the culture plates grew aspergillus, both on the blood agar as well as Sabrad's dextrose agar. A revised diagnosis of right eye fungal scleritis was made, and patient was started on hourly antifungal eye drops, along with cycloplegics and systemic voriconazole 200 milligrams BD. Little did we know that we had another surprise in store, the unexpected lockdown. However, the patient could sort to telemedicine, and she judiciously used her eye drops along with systemic antifungal tablets. 2 months after lockdown, she presented to our OPD again with a vision of PL plus PR accurate with the opaque vascularized cornea and ciliary staphyloma. There were no active infiltrates, and patient was also symptomatically better. The lessons learnt were, not all scleritis are immune mediated. Atypical presentation warrants a scraping or a scleral biopsy. An inciting cause could be either a pterygium or a cataract surgery, and fungal scleritis may mimic surgically induced necrotizing scleritis, leading to a delay in diagnosis. A burnt finger, always remember the fire.
Really a fantastic case, Vandana. Very nice case. And
Thank you, sir. Thank you, sir.
any systemic workup done for this patient?
Yes, sir. The patient was actually from Namakkal, and initially there was no systemic workup that was done for the patient. So we saw the patient, and given the history of pterygium surgery and exact area of melt in that particular area, so we just started her on systemic Visolone along with intensive lubricants, and we asked her to review after 5 days so that we can do the systemic workup. So when she came after 5 days, and she was more, the things had worsened than what it was before. And that is when, while doing the systemic workup and before planning immunosuppression, we just did a routine scraping. And to a surprise, it turned out to be aspergillus.
What are the systemic workup tests? All the routine tests were done?
Everything was done, sir. Everything was done under with the rheumatologist opinion. ANA, ANCA, everything was done.
Everything was negative?
Everything was negative, sir. Everything was negative.
So what are the factors when we should have a high index of suspicion for fungal scleritis?
First thing is, if the scleritis is going to extend from the sclera onto the cornea, I think that is one of the main factors which will tell you that it is not an immune-mediated scleritis and it could be an infective scleritis. Second thing is the vision. So much of drop in vision is usually more observed with an infective scleritis rather than an immune-mediated scleritis. And such fast progression and with topical steroids, initially all these patients tend to show some improvement, and later then they spiral down and there is a worsening.
Over to the jury.
How did you do the scraping in the sclera?
We actually, yes, sir. From the scleral bed, we could actually take a bit of scraping. So we could take a bit of scraping from the scleral bed and a little bit from the peripheral cornea as well.
Sclera is so thin, that area, no?
There was at the margins, there were a little bit of like plaque-like lesions that we could take, sir. So we just took very little and just mounted it on only the blood agar and STA agar. Even if you look at the STA agar, there is just only one area of mount. That is the amount of material that we could get. Very little material.
Yeah. JK, you want to say something?
No, I followed the case. So
yeah.
So we followed the case, and this is my colleague case, and we discussed both together. So in this particular case, my advice is whenever we have some problems, it is a collective decision. I found it is making much things better and able to solve many problems. When we had first time, the patient didn't do as expected, like a scleritis. Immediately we all came together and we had some discussion, then did a scraping. Otherwise, we could have missed the totally patient and land up in a vaccination.
Nirmal?
He is not available presently, sir.
Oh, he's not available. Okay. Ramakrishnan, sir?
Yeah, it's a good case, but Reddy and Dr. Vandana, I want to ask the
Yes, sir.
was done 5 years back, no?
Yes, sir.
You have done used any mitomycin in that case?
Actually, pterygium was done in an outside hospital, sir, and
You're not sure
this
whether
patient
they
was
have done it.
referred. Yeah, so we did not have any surgical records to prove if any mitomycin was
Usually,
used.
so sometimes the dose of the mitomycin is more. We have seen many cases of scleral necrosis following
Yes, sir.
mitomycin.
Yes, sir.
I think
Yes, sir.
Can it be a secondary movements, Dr.
Unlikely, sir. The presentation was not so, because even after giving, initially we had, when she presented to us, we gave her systemic steroids, and that only worsened the case. It did not improve the case. So more was pointing towards it that it was not an autoimmune, it was not an immune mediated mechanism at all in the first place.
And what about necrotizing scleritis?
That is the reason why we had started Visalone first in the first place, and that is why we thought it was worsening, and we wanted to switch to cyclophosphamide, because all case reports have shown that more than steroids, cyclophosphamide gives better results for all these kind of necrotizing scleritis. Only then, prior to that, doing the routine scraping, we found out that it was actually a fungal scleritis and not a necrotizing scleritis.
Oh, in this, yeah, okay, fine. But in fact, the treatment of the use, you had the scleral thinning and uveal prolapse was.
Yes, sir. We actually did not.
Graft will be of use. You have done any patch graft to
No, sir. Unfortunately, 1 week after, like exactly 6 days after we started the patient on topical as well as systemic antifungals, lockdown was imposed, and the patient was from Namakkal. So the only way that we could actually follow up the patient was just gross pictures on WhatsApp and talking to the patient of how she was feeling. And only with the we had given her enough stock of antifungals, when she had left. Otherwise, she would have to come here and mix and go. So she was just using the antifungals and systemic voriconazole for approximately 3 weeks and antifungals for almost approximately 1.5 months. So only when the lockdown was lifted, we could see her. Probably if we had seen her a little earlier and if things had settled down, maybe we could have planned a surgical intervention. But because of the lockdown, we couldn't.
Okay.
Yes, sir. I think she has managed the case very well. I think the vitritis probably opened the eyes for them. No? The vitritis, yeah.
The vitritis, sir, as well as the increase in the corneal lesions, because within 48 hours, we could see a gross increase in the corneal pinpoint lesions. Only after seeing the patient and going back to case reports, we started realizing all this. Because even case reports say that in all these cases, it is better to take a scraping from the sclera rather than not the cornea, because initially the lesions are all mid-stromal and deep stromal, and they're not antidistromal. So your corneal scraping can still come negative, and patient could still have a fungal scleritis.
What is the ultimate vision for this patient?
Right now, it's PL plus PR accurate, sir, and on B scan, retina is on.
Retina, what about the vitritis?
Vitritis there's no vitritis right now, sir. It's settled, and there are no membranes as well. No.
Okay.
She was on prolonged systemic antifungal treatment for almost 3 weeks. She had taken voriconazole.
A very nice case, very interesting discussion also. And over
Thank you,
to
sir.
Supreme Judge.
Vandana, in
Yes, sir.
addition to mitomycin as the culprit, as a possible culprit, history of prolonged usage of post-operative medications, especially steroids, could also be another culprit, because these people, they see this fleshy graft, think that the wound has not healed, and they continue to apply this steroid medication for a long period of time, which could also result in this kind of a lesion. So, was there any history recorded regarding the post-op use of medications?
So she was a 60-year-old patient, and the surgery was almost 5 years back, sir. So she could not recollect anything of that sort. Even the pterygium surgery was actually because the hospital which had referred us, they had mentioned that a pterygium surgery was done, and only after inciting the history a lot of times, that is when she told us that she had a fleshy growth and surgery was done. And otherwise, no other positive history was there.
What surgery was done? Pterygium with autograft?
Yes, sir. Pterygium excision with autograft was done.
No,
Yes.
but what Siddhartha is pre-operatively, because many patients with pterygium are put on steroids pre-operatively for a long time, even before the surgery. For a
Yes,
long
sir,
time, they treat with surgery with, just to reduce the congestion. So,
yes, sir.
and the inflammation there. So I was wondering whether the patient was put on steroids for quite some time.
No such history, sir. No history as such.
Anyway, it's a very nice, interesting case. Fungal scleritis,
Thank you, sir.
very, very rare, but we have to keep that in mind when the patient doesn't respond to steroids. So
Definitely, sir.
It's always we have to, whenever the patient does not respond, the take-home message is, whenever the patient does not respond to the steroid, revisit the diagnosis. Revisit the diagnosis and make a collective decision. J.K. Reddy, I think, put the things right here. Make a collective decision, putting everything together, and all the consultants, because each one will have a different opinion. Ultimately, for the benefit of the patient, that is more important. Supreme Judge, your verdict.
Excellent, very nice. And I only wish we had more data about the patient so that it will help us in preventing such episodes in the future. Well done, Dr. Vandana.
Thank you, sir. Thank you so much.
Self Garland.
Thank you, sir. It's a virtual program, so I think I'll just put a virtual garland.
Thank you very much, Dr. Mohan, and hip hip hooray to TNOA for a wonderful, most enjoyable webinar. Thank you.
Thank you, Chitra, for being with us. And Ravi Shankar, over to the vote of thanks.
And Mohan,
thank you.
Mohan, how come all your productions are Silver Jubilee productions?
We are also Silver Jubilee. Rajanaikar also.
Thank you everyone for joining us. Court Martial webinar, and I should really thank the Tamil Nadu Ophthalmic Association, the August Paras and the Management Committee, and the advisors of TNOA for giving us this opportunity to conduct this meeting. It's been happening in these turbulent times. Definitely sharing knowledge, even when we are at home, is very important. That's what TNOA always, the flag flies aloft always. Thank you, and I would like to thank the Supreme Judge, Dr. Siddhartha, for having consented to be the Supreme Judge today and giving his verdict and the man of garlands today. Thank you, Dr. Siddhartha, and I would like to thank the honorary jury, Dr. Sukumar sir, in fact, leading his IMA meetings and being here all through the day. Thank you, Dr. Sukumar sir, for joining us, Doctor. Thank you. You've been so inspiring. You've been so always telling us to go forward and doing this meeting, sitting for the whole meeting, Dr. R.K. sir. Dr. Nirmal Frederick, though you had some DOS meetings, you had time to spend with us and given your very good take-home messages. Dr. Chitra, thank you once again for joining us, and you've been a little bit expert in court-martial always, and you know things better. And finally, Dr. Teddy, who's a man of innovative ideas always, and a bold man to say, let us innovate and experiment things. Thank you, Dr. J.K. Reddy, for joining us and making it more lively. I would also thank the audience. If not for the audience, I would like to mention that this TNOA webinars have a good audience in Facebook. Always there's a folk who's following TNOA with excellent quality and the knowledge so beautifully. Thank you, audience. The medical support team who has supported this meeting, virtual webinar, the Lupin Blue Eyes Medical Company, Mr. Patabi, the regional manager, and our team. Thank you for supporting us, and a big thanks to everyone. Enjoy, be safe in this turbulent COVID times, and get along with your profession excellently, and do well and have a fantastic end of the year. Let the year finish soon. We want 2020 to finish soon, and looking forward for a bright 2021 and looking for a New Year meeting. Dr. Mohan Rajan is planning for his Eve meeting. Let us decide the day. Very good webinar with the New Year Eve. Thank you once again. Thanks a lot for this. Dr. Mohan, please.
I think you summed it up very well, Ravi Shankar. It's been really a fantastic meeting. Court Martial, all the jury members were really fantastic. All the speakers were really wonderful, and Supreme Judge was really supreme. And Siddharthan, thanks a lot for the nice inputs, and they were very humorous inputs as well. We wanted to make sure, because it's on YouTube and Facebook, and that is the reason we didn't want to be very what you call the typical court martial. We took in a lighter vein, so that because this is accessible to even every member of the public as well, YouTube. So we want to make sure that we don't have any derogatory remarks on anybody, and that is the reason why. And all the speakers are really fantastic. Dr. R.K. Sir, Sukumar, Dr. J.K. Reddy, Nirmal Frederick, Chitra Ramurthy, thank you very much for the wonderful support. And all the speakers, very young speakers, very dynamic speakers, they all did a wonderful job, covered all the topics, and both medical and surgical topics. Thank you very much. Lupin Blue, of course, great support. And without any flaw, the entire webinar went from front to back. Thank you very much. And we meet again soon.
Thank you. Thank you. Thank you, Mohan.
Thank you very much.
Thank you, Mohan. Thank you, Ravi.
Thank you. Thank you, Sumar sir.
Thank you.
Bye.
Thank you very much, sir, for giving this opportunity.
Patabi, thanks a lot.
Thank you very much, sir. Thank you very much.
Yeah, yeah.
Thank you, Lupin and Numeratic. Thank you very much. Thank you, Mohan.
Thank you very much, sir.
Thank you, President.
Kumar, bye.
Big thanks to the President and Secretary for giving us the freedom. Yeah, giving us the freedom, and always being dynamic at the top.
You're doing a wonderful job. Must give you freedom. Must give you more freedom.
Thank you, boss.
Fantastic. Yeah, fantastic.
Thank you, sir. So can I end the meeting with your permission, sir?
Thanks to Sukumar sir. Sukumar sir left all his meetings and
Thank you.
thank you, sir. Thank you.
Bye.
Thank you very much.
Thank you, sir.
No.